Hello, everyone. Welcome to our Spine Time webinar series. My name is Joshua Weaver. I am a neurologist and one of the co-directors of the Weill Cornell Medicine Center for Comprehensive Spine Care. As many of you may know, we've been running these webinars over the past year or so on a variety of topics, and we're really excited for this topic today. Slightly different format than what we've been doing before, and I'll talk about that in a second. I just wanted to say it's a great pleasure, to have everyone here on behalf of the other co-directors and the staff here at the Spine Center. Today, the topic is going to be on CSF leaks, so that's cerebral spinal fluid leaks, which you may not be familiar with, but we're going to go over the risks, the symptoms, and the treatments of this spine disorder. And I just wanted to say thank you to our speakers today, who I'll introduce in a second, and also to our staff, Roseanne, Tatiana, and the rest of the neurosurgery group at Cornell for putting these webinars together. It's a lot of work. As you may know, our Spine Center is located at 59th Street and on the second floor. And we are a group of doctors who are all under the same roof, and we are a multidisciplinary team consisting of a lot of different types of doctors that takes care of spinal disorders. So we have me, who's a neurologist, and I put myself in the middle there. And we also have physiatrists, rehab medicine, pain management doctors, neurosurgeons and orthopedic surgeons who deal with spine surgery. We also deal with our integrative center, integrative medicine center, a lot of complementary and alternative medicine. We also work closely with our neuroradiologists, and we actually have one here today who's going to be talking to us. Yeah, we really, our philosophy here is that we take care of people in a holistic way. And we try to really look at the whole person and try to go over all of the things that can happen with their spine and have a lot of different doctors taking care of them. So I just wanted to introduce our speakers. Dr. Daniel Pack is an assistant attending anesthesiologist who works in pain medicine. Dr. Levi Chazen, who is an associate attending radiologist and associate professor of radiology. He actually joins us. We have weekly or biweekly conferences where we discuss complicated cases, and Dr. Chazen is a frequent member of that who goes over the radiology images with us, and we really love having his involvement at the Spine Center. And Dr. Jeff Greenfield, who is the Vice Chairman for Academic Affairs and Associate Professor of Neurological Surgery. He's actually a pediatric neurosurgeon, but he deals with a lot of spinal disorders and particularly knows a lot about CSF leaks. So excited to hear about that. Today, we also have an interesting situation where we actually have a patient who's going to be speaking with us as well. And we're excited to hear about a personal experience with someone who's had a CSF leak and kind of the journey that he went through to get treated. So without further ado, I'm going to kind of pass this on to Dr. Pack. And before we do that, I just want to remind everyone, if there are any questions, please put them in the chat. I will be monitoring that. So anyone who has any questions as they pop up, just put them on in, okay? Dr. Pack, why don't you take over here?
Thanks, Dr. Weaver. So it's really a pleasure to be here. I'm going to try to, at least for my part of the discussion, keep it fairly brief so we can get to questions and also give some of my co-speakers plenty of time to talk. But just as a really quick introduction without going into too much detail, the brain is supported by this fluid called the cerebral spinal fluid, as mentioned, or the CSF, which essentially acts like a physiological shock absorber, more or less, for the brain and also the spinal cord. And it also serves as, you can think of it as kind of the nutrient delivery system also for this for the central nervous system. Now, the CSF is also encased and enveloped by what we call the meninges, or it's a complex layer of membranes, which serves to protect the central nervous system and also serves as a barrier from the rest of the body. But it's a dynamic system. So the CSF is constantly being produced and being replaced, and it's produced in these cavities called the ventricles, which is in the brain, which you see there on the right. And so it's replaced and turned over about 3 times a day. So as you can imagine, a really dynamic process. Next slide. So in some cases, you can have a disruption of this more or less contained system which is the topic of discussion today. So there can be many causes, and we've listed them here. So here are some of the common ones. Trauma, certainly after skull fractures, for example, or penetrating head injuries can cause leaks. Whiplash injuries, where there's kind of a high velocity back and forth motion at the cervical spine or the head, has also been connected to causing CSF leaks too. Different anatomical abnormalities, so bone spurs and degenerative disc disease can actually cause some wear and tear, especially kind of the front portion or the ventral portion of the meninges can also cause a dural tear too. We see these in iatrogenic cases. So what this means is it can be an unintended consequence from a medical treatment. So some patients will get lumbar punctures where the proceduralist or the provider will actually purposefully take a little bit of the fluid to sample it. And so if you can imagine, that's obviously causing an intended leak there. Sometimes after epidural anesthesia or an epidural steroid injection, which we oftentimes will see in the pain clinic, if there is a violation of that dura or the meninges, then you can also see a leak. Can occur after spine surgery or any kind of intracranial surgery. So again, not terribly common, but not unheard of either. These can also occur spontaneously. So these are fairly rare cases. We see it more frequently in patients with different types of connective tissue disorders, such as Marfan's or Ehlers-Danlos. We won't go into too much detail about those. But as you can see here, really a variety of causes that can lead to this type of issue. Next slide, please. Now, as I stated, spontaneous leaks are rare. And I think the number is somewhere around 5 in 100,000. So not all that common. But as I mentioned before, it does occur more likely in patients who have this pre-existing weakness of the dura mater, which again is the outer portion of those meninges. And so when you do see these spontaneous leaks, they tend to occur more in the spine, specifically the thoracic or the cervicothoracic junction. So as a point of reference, as you can see there with the cursor, tends to be more kind of in the area like in the base of the neck. So this is where we see more of the spontaneous leaks. Next slide. So the CSF protects the brain from jolts and knocks and supports the brain against gravity. So it floats in kind of this natural buoyancy and is suspended in the CSF. So if you can imagine when there's a break in this barrier or a break in this system, even though the body is essentially able to turn this over multiple times throughout the day, the brain loses this buoyancy. And so it can then cause this essentially a downward traction on a lot of these pain sensitive structures inside the head. So that includes nerves, the meninges also can get irritated. And so this phenomena is called intracranial hypotension. And what you see from the imaging there is there are some kind of pathognomonic signs that Dr. Chazen will go a little bit more into detail about, but you can see some downward shifts in terms of some of the structures in the head. So oftentimes it's a clinical diagnosis, but we'll oftentimes pursue diagnostic imaging like MRI imaging too. Next slide. So what are the symptoms? The hallmark for much of this is what we call postural headaches. So headaches that get worse with being upright and standing, and improves usually when lying down. But there's a lot of variability there. So it can be focal, it can be generalized, it can be in the back of the head, it can be towards the front of the head. The headaches can be mild, they can be severe depending on the extent of the leak. And there's a lot of other symptoms that can accompany this. So neck stiffness, nausea, changes in hearing, visual disturbances. So it can be pretty disabling. The positional nature of these headaches is due to the worsening traction on these pain sensitive structures that I mentioned before in the upright position. So everything works by gravity. But these can lessen over time. And especially for patients with chronic CSF leaks, the positional nature may actually be lost. So I think what's important to mention is that not all positional headaches are CSF leaks, and not all CSF leaks are positional in nature. So there is a little bit of variability there. Next slide, please. So obviously there's other types of headaches, and these can also be, I've listed some of them here, and they can all be positional in nature. So they range from migraines to different types of bleeds, and also more benign stuff like exertional headaches. And so what I'll say is that if you are presenting with these headaches, it's important to present to a provider for a closer evaluation. Now, in terms of treatments, I don't have another slide for this, and Dr. Chazen will go into a little bit more detail about the interventions. We always try to manage these conservatively. So typically what we'll advise patients is to do stuff like rest, to increase their fluid intake, also to consume caffeine. And so there's a thought that caffeine may actually increase the production of this CSF. And then also different types of medications, so anti-inflammatory medications and also medications that oftentimes we'll use for migraines like Furoset. When these medications have kind of run its course and the headaches tend to be a little bit more persistent and pretty disabling, which we oftentimes do see, then we'll pursue something called an epidural blood patch. And this is actually a procedure where we take the patient's blood and inject it into the area where we suspect the leak is occurring. And what that essentially does is you can think of it as kind of patching up the space. That's somewhat of an oversimplification of that particular type of treatment. There are other thoughts that it may actually have an impact in terms of the hydrostatic pressure in that area, and may also have other different types of mechanisms of actions, which are kind of beyond the scope of this discussion. But in any case, for patients where we especially have a known cause, tends to be pretty effective. And oftentimes patients leave within a couple hours with resolution of their pain. But I'm going to reserve some of that discussion to Dr. Chazen, so I'll turn it over to him.
Thanks so much, Dan, and thanks everyone for inviting me. Great to be with you. Do you want to go to the next? Okay, perfect. So I'm going to give kind of a quick overview here of some of the diagnostics and treatment for spinal fluid leak, and hopefully we'll have some time for questions. And one thing I'll say is, this is really an interdisciplinary effort to treat these, and they're very satisfying from our perspective, because even patients that have had spinal fluid leaks for many, many years, if you can effectively find and treat the leak, it's really a clinical cure. Patients can get absolutely back to their baseline, even if you've been quite debilitating. So diagnostically, patients usually present with clinically suspected SIH, that's an intracranial hypotension. And the most common symptom, as Dan mentioned, is orthostatic headache. So it's a very specific type of headache. The headache is bad when patients stand up, it's better when they lie down. Therefore, the headache is usually better in the mornings because patients have been lying down to sleep all night. And then the afternoon and the evening, the headache comes on, and it's usually relieved within about 10 or 15 minutes of lying down. So particularly if that symptom is present, and there's a clinical suspicion for a spinal fluid leak, the first test is actually an MRI of the brain. There are some characteristic findings, I'll show some of them to you, but things we look for in the brain MRI that can really increase the specificity of a spinal fluid leak. And, we're talking about leaks in the spine, but the manifestations of that will be on the brain MRI. If the brain MRI is positive, then we'll oftentimes recommend a spine MRI. And that's to look for, I'm getting a little bit into some detail here, but just so everyone gets an idea of how we think about this as physicians, that's to see broadly if there's a fast leak. So we see signs of leaking fluid around the spine, and that's called an epidural collection, or a slow leak, and that'd be a spine MR with no epidural collection. Based on whether or not those are present, we'll recommend some specialized types of myelograms. There are CT myelograms. As we're going to hear from Mr. Verde in a little bit, there are CT myelograms where we're actually on your side. So these myelograms come in many different flavors, and they're not all the same. There are MRI myelograms where we put a little bit of MRI contrast in your spinal fluid. So I won't get too much into the weeds there, but that's sort of the mainstay of diagnosis. Now, the treatment pathway on the right, as Dan mentioned, the first line treatment is blood patch. And it's very reasonable in a patient who has suspected CSF leak to do the blood patch before pursuing some of these diagnostic studies like a myelogram, because the blood patch is actually what's going to help the patient get better. We may actually repeat the blood patch a few times. If a patient has a spinal fluid leak following a lumbar puncture, which is a very, very common reason to have a spinal fluid leak, that blood patch is going to be over 95% effective. There's a very, very, very high chance. One blood patch, the leak is resolved, and that's it. If it's a spontaneous leak, it just came out of nowhere, it can get a little more complicated. So based on that, we'll often recommend repeating the blood patch, and then we may add some fibrin. Fibrin is a biological glue. So it's, if you cut yourself into scab forms, your body deposits fibrin. Fibrin is used by your body all over, but we're able to sort of recreate that and actually inject that in a targeted way. If some of these minimally invasive treatments don't work, we'll refer the patient to Dr. Greenfield to actually do surgery on the site of spinal fluid leak. So that's kind of a broad overview. You can go to the next slide, Josh, please. So as Dan mentioned, you have about 200 milliliters of spinal fluid, the average person, and you make about 600 a day. So you only get these symptoms if the rate that you're leaking the spinal fluid is greater than the rate that you're producing it. And it's not like it's leaked out into the environment, your body resorbs it, but ultimately your pressure of your spinal fluid gets low, and that's why patients have symptoms. Can you go to the next slide? This is based off something called the Monroe-Kelly doctrine. It's basically the idea is if you have an intact skull and you're losing spinal fluid, the body's got to compensate. So what the body does is increase the blood compartments, and you can get things like subdural hematoma. So blood in the brain, but it's actually a compensation for the spinal fluid leak. So these things can get quite complicated. A patient can present with headache, have subdural hematomas, and it's actually secondary to a spinal fluid leak. So you got to get to the root cause of the issue. Can you go to the next slide? So here's a characteristic brain MRI, and what the black arrows are pointing to is enhancement. So we've given the patient some gadolinium in their IV, and these areas are lighting up, and that's just again the body trying to compensate for the low spinal fluid pressure. Now, what's really interesting is if we successfully treat a spinal fluid leak, those changes will resolve. So you can see the before and after treatment on this slide, and all that enhancement will go away if the leak is successfully treated. Next slide. Here's another example of a patient with a really pronounced spinal fluid leak. And you'll have to take my word for it. I can't go over all the findings here, but this is quite a pronounced case. And if you show the next slide, Josh, after successful treatment, you can see the area of the brainstem at the bottom is much more normal appearing. And again, you can see this pre and post treatment changes on the MRI very quickly if the spinal fluid leak is treated successfully. Next slide. So in terms of spontaneous leaks, so these are people living their lives, generally healthy, a little more common in females, peaks around generally patients in their 40s or 50s. And all of a sudden, out of nowhere, they get this orthostatic headache, a headache that's bad when they stand up, gets better when they lie down. What we've learned is these fall into a few different buckets. The image on the left is showing what's called a dural tear. So basically, a normal part of the bone forms a little sharp knife, and it can just tear that watertight layer and cause some spinal fluid leakage. The middle image is what's called a perineural cyst, also known as a meningeal diverticulum. It's basically like if you were to overinflate a balloon, the lining gets thick. So it's a normal outpouching of spinal fluid, but it kind of balloons out and can get very thin and spring a leak and leak some spinal fluid. And the last image on the right is showing something that was actually only described about 5 years ago in the literature, but we're seeing more and more of. This is a fistula, or an abnormal connection from the spinal fluid into a vein. So these patients are losing spinal fluid into their venous system. It's being resorbed by the body, but the pressure drops in the spinal fluid, and that's what gives them symptoms. Next slide. So here I'm just going to give you a really quick general idea of what a myelogram looks like. So we'll bring a patient in, take a picture of their spine. This is a CT guided lumbar puncture. So a needle is going down into the spinal fluid, some dye or IV contrast being injected. And then on the next image, we can get these two images on the left are what's called an MRI myelogram, just a little drop of gadolinium, and the image on the right is a CT myelogram. So basically we inject this dye and we see where it goes. And if we see the dye leaking out, we can infer that's where the spinal fluid is leaking out. And that's just the basic concept of a myelogram. Next slide. Can you pull up the images here, Josh? Just click a couple of times. This is just going back to what I said earlier, where generally we think about, just go to the next image, Josh. Thank you. Generally, we think about, are these fast or slow leaks? And that's based on the spine MRI. I won't get into too much detail here, but it's important to understand that not all CSF leaks are the same. And depending on what's causing the spinal fluid leak, and if the fluid is leaking out rapidly, if it's a very slow, kind of indolent leak, the diagnostic studies can be totally different and the treatment can be totally different. Next slide. As I mentioned, the treatment's collaborative. You really need a good team, which we have here at Cornell. And, generally we'll try some of these non-surgical treatments before recommending anything invasive. If those don't work, then we recommend surgery for a definitive treatment. Next slide. Here's just a graphic of a blood patch. As Dan mentioned, we take some of your own blood and put it around the dura. The simple way of thinking about this is if you have a leak, as shown on that left-sided image, and you put some blood there, it sort of forms a scab over the leak and that falls off. Next image. And here's a picture of the biological glue, so-called fibrin, that we can also use. So we have a few tricks up our sleeve, but for those cases where we can't treat the spinal fluid leak through a needle, fortunately we have Dr. Greenfield and his expertise to treat these surgically. So I'll let him take it from here.
Well, thanks. That's a really great intro, and you guys did a wonderful job really outlining most of the ways that patients present with CSF leaks. I'll sometimes get patients come to my office as a neurosurgeon with the referral that they've been diagnosed with a CSF leak or think that they have a CSF leak. And I kind of have to push them away and refer them back to the neurology and interventional neuroradiology teams, because again, so much of this is diagnostic and then non-surgical. Interventional doesn't mean non-surgical. It just means that you can do things without actually going to the operating room, and the radiologists can do fantastic and highly effective interventions in their suite with just mild sedation. And so that's kind of where the interplay between neurology and neuroradiology and then neurosurgery becomes really important. And so to have a team that actually communicate together and work in this way is highly advantageous. And so it's been a pleasure to work with the team in this way. Just by way of sort of explaining how I got interested in CSF leaks and why I'm even part of this team, I'm a pediatric neurosurgeon, and I take care particularly of a population of patients that have a herniation of their brain from a different reason, something called a Chiari malformation. It's a fairly common phenomenon. It can be really debilitating for other reasons, but it often gets mistaken for other things. And one of the other things in this circle here that I've outlined for you here that Chiari can be mistaken for is a CSF leak, and vice versa. CSF leak can be mistaken for Chiari, along with a bunch of other problems that I'm not going to get into. But that's just sort of how I sort of started seeing these patients and recognizing that these weren't patients who had Chiari malformation. They were patients whose brain were herniating down, and either radiologists who weren't familiar with it or their internists were sort of taking the reports and sending them for inappropriate referrals or surgical evaluations. And so I became sort of my own, student here and tried to learn about it over the past few years and started working with Levi and the spine team to figure out how to address these. So when you come to me, it's sort of the end of the line. There are all these different interventions here, and just go forward one more time. And so the way that I view myself in this is I'm sort of the least important. I don't mean to be self-deprecating. I'm just sort of the plumber here. I'm fixing the leak. If there's something that can't be addressed with sort of the minimally invasive interventional means, blood patches or fibrin sealants, then sometimes we have to get a little fancier. And the diagnostic maneuvers can sometimes get fancier, trying to find these leaks that aren't responding to blood patches or aren't being evaluated by standard MR evaluations. And Levi had alluded to that. Sometimes more complicated interventional myelograms, including decubitus myelograms, may be necessary. So lots of interventions are possible, but only with the right diagnostic workup. Next slide. Here's a really classic example of a girl that I took care of who had what looks, by all intents, to be a classic Chiari malformation with something called a syrinx. It's a large fluid collection in the spinal canal that Josh was highlighting there. It looks like a sausage, and it's basically filling the entire canal. They actually had surgery for the Chiari malformation, and not surprisingly, didn't get better because the problem wasn't the Chiari malformation. The problem was that they actually had a fistula. You can see there down in panel D. This was actually diagnosed by Levi, and it's a sort of a classic sort of radiographic image here that, again, we didn't really know about 5 years ago, where the CSF, which is bright in that picture, is sort of leaking out into that little vein. It's pretty subtle, but that is absolutely abnormal. And so the management to fix both the brain sagging down, all the fluid accumulating in the spine, and all the symptoms is just to clip that little area where the fluid is leaking out. On C, those images probably should be reversed. The brain went back up into the head, and all that fluid in the spinal canal completely resorbed and resolved on its own. I mean, that's a remarkable change, but a really clear image to explain how this simple little leak miles away from the brain neurologically, all the way down in the thoracic spine, affected everything up in the head. And Mr. Verde, who's going to be on at the end here, is going to relay his own personal experience with this exact same phenomenon. Different MRI scans, but same phenomenon. Next slide. I think Levi on the last slide had kind of this classification, not so important, just to know that there are all different types of spontaneous leaks, from these tears where we actually have to go in, do surgery, and actually sew up a complete tear. And we've had a few cases where we've actually identified herniated discs or small pieces of bone fragments that have actually torn the dura, and we actually remove the bone fragments, fix the leak with regular sutures, like normal surgery, and can fix the entire process. But that's a minority of those cases. The diverticulum and the fistulas type 2 and type 3 are sometimes trickier, that really need the collaboration between neurology and radiology to help us figure out and hone in on where that problem is. Next slide. And so to do a planning for this, it's actually pretty complicated. It involves not only the radiologist, but also an interventional neuroradiologist, where we actually do a special study to look where all the arterial supplies are to the spine. And it will involve a spine surgeon to do minimally invasive spine surgery as well. We can actually take care of these surgeries through a little tube. We used to do them sort of like through an open traditional surgery, but we've recently converted to a little bit more of a minimally invasive surgery. And again, Mr. Verde will hopefully tell you what it felt like to go through that procedure, because he was a recipient of that type of procedure. But we really just need to find that one small area where the spinal canal and that vein are connected. And as long as we clip those connections off, everything else takes care of itself. And I think I have a picture in the next slide of what that looks like. So on the left side, you can see that whitish pearly area. That's the dura, that's the covering of the spinal canal. And a slightly wider picture is just sort of a little area that we've drilled out. With the drill, you can sort of see the edges of it. And then on the right side, you can actually see the tube a little bit more clearly, because there's now a clip. This is actually an aneurysm clip, which is straight across the connection between where the CSF was leaking out and the vein. You can't see those structures, they're inside the dura, but that has a high closing pressure on that clip. And so it basically blocks the communication between the CSF leaving the canal. And in all the cases so far that we've identified, so as long as Levi can find the fistula, we've been incredibly successful at closing off these leaks. And so again, just, it's a matter of technology finally catching up with something that's probably been around forever, that patients were just sort of unaware of and were unable to get treatment for. Next slide. And here, just to sort of work our way in here, I think I may have made Mr. Verde a little bit younger than he is, but I'm sure he'll take it. This is a gentleman who came to our attention earlier this year, has been suffering with severe headaches, and was actually found to have a large hematoma. Levi mentioned before that if CSF leaves your brain, it's going to fill up with blood or something else, and in this case, it was blood. And his brain was actually being pushed over. You can see pretty dramatically it's being pushed over, and on the middle screen, you can see all the mixed density. That's sort of blood of different ages and cysts and everything kind of accumulating outside the brain and pushing on the brain. And on the right side, just to corroborate again what Dr. Chazen said, that kind of enhancement around the outside, very classic picture that this is an intracranial hypotension. The brain is under low pressure. So next slide. So intracranial hypotension was diagnosed, the myelogram was indicated, we did it, but we couldn't actually find the leak, right? So frustrating for the patient, but next, just click over 2 more here. We didn't give up. We recommended a decubitus myelogram. This is actually the neuroradiologist, not me. And when they turned Mr. Verde on his side, the dye eventually leaked out and identified that fistula. And a very excited series of emails and phone calls ensued where people said, you got to fix this fistula here. And so he was taken to the operating room to go ahead and do that procedure, which I showed you on the last slide. Go forward one more. You know, when I was putting this together, I was like, well, this would be wonderful if we didn't actually just tell you how we look at it, but actually if you could hear about it from the patient side. And so I reached out to Mr. Verde, and he just in 2 seconds responded that he'd be happy to share his experience. And so in terms of how he went through this process, how he found the team, what it was like, what the recovery has been like, however he wants to share this experience, I thought it'd be really invaluable for the folks joining our Spine Time, just to hear from the patient directly. So why don't we let him talk for a few minutes, and then maybe we can open it up to questions, and we'll all be able to jump in and share our thoughts together. So thanks so much for inviting me.
Mr. Verde, can you unmute? Are you able?
Okay. Okay. All right. So yes, it's kind of interesting to find out what I had went through. Just hearing the people who were involved describe it. It started last August where I started getting increasingly severe headaches. They were orthostatic, although I didn't realize that at the time. I thought it was too much caffeine, not enough caffeine. I was grinding my teeth, all the things you might think, until I finally went to a neurologist in November, and she correctly called a CSF leak, which was confirmed by the MRI. It seemed to resolve a little bit on its own, and then it came back much stronger than ever. And it's hard to describe because it's a combination of the worst headache you've ever had, with nausea, constant nausea, vertigo, motion sickness. And one very strange thing, sometimes people would talk and they'd sound like cartoon robots, which is a very, very odd thing indeed. And it got worse and worse to the point where I could almost not work. I was spending as much time trying to lie down to alleviate the symptoms as sitting up. In the middle of March, I went in for an extended 2-hour session, the MRI, to check the brain, the spine, everywhere they could, to see if they could find where the leak was coming from. I had a blood patch, really didn't do very much. And when I came out of the machine, it was about 9 o'clock at night. I was told by the radiologist, you have to go across the street to the emergency room. You've got, well, I think you've all seen it now. Your brain is not in good shape, and you have a very significant hematoma that needs to be addressed immediately. So this was the first time I met Dr. Chazen and I met Dr. Greenfield. And they work together. And I have to say that one of the things that's most amazing about this is to get the radiologists and the neurosurgeons working together is such a tight team. That's what made this work. And I didn't realize it at the time, but I guess it was a little bit dicey because normally they drill to get the blood, they do a craniotomy to get the blood out of my head, but that could only make the bleeding worse or make the brain sag worse. And so the radiology team, after they realized they couldn't find any leaks after 2 hours of MRIs, figured out it must be a venous fistula. And so my understanding is that they used an algorithm to try and isolate the area where the venous fistula was likely located. And then I did a 2-hour session in the CAT scan to try and find it with dyes and twisting and turning in all different directions to get the dye moving in the right direction. And it was actually kind of fun because, as awful as everything was at the time, everybody in the CT scan team was completely focused on finding it. They were determined not to let me out of there until they figured it out, and they did. And they were high-fiving each other. I could hear them cheering from the control room because this is a very, very difficult thing to find, and they found it. And once they found it, Dr. Greenfield is being a little self-deprecating. Knowing how to fix the leak is not just this is not plumbing in the normal sense. But once they figured out where the venous fistula was and what had caused it, and it was basically a cyst from an old back injury I had that had grown into a vein, the walls between them disappeared, and the CSF was flowing out through my veins. And so they were looking for a leaky faucet and found out it was basically an open tap that was the problem. And then in the space of a day, I had a myelogram to sort of do a reconnaissance mission of where the blood vessels were around the venous fistula, and then followed in a couple of hours by the surgery to clip it. And the most extraordinary part of all this, I mean, this is all happening in the space of a week, so it's, you know, a little bit getting blindsided, but how I was getting constant visits from the radiologists, from the neurosurgeons, from the neurologists to track it, and when they found it, right in for surgery. And then the most amazing of all was I didn't realize how bad I had been feeling until I woke up in post-op, which is normally not a great experience, and realized the pain, everything had stopped, just stopped. It was like had never been there. It was truly extraordinary. And I'm about a month and a half now post-surgery. Everything's looking good, and I feel better than I felt certainly since August and probably in years. And I think both Dr. Chazen and Dr. Greenfield said, well, this is the kind of thing we can fix. We literally just go in and fix it. We put a clip in it, and it fixes the problem. You're cured. Not something that you get to say in medicine that often, but it worked an absolute treat for me, and I'm very grateful that the teams were able to work in conjunction and figure out not only what this was, but where it was. And that was critical in getting the successful treatment that I got.
That is really great. Thank you for sharing that, Mr. Verdi. It's always nice to get the patient's point of view. You know, we often read about these things, we see the images, but it's so great to actually see someone, you know, who successfully recovered from all this. Your case was obviously a really complicated case. You know, this is not your run-of-the-mill CSF leak, and it's great to see this multidisciplinary, you know, effort to really treat this. You know, we have some questions that have come up in the chat, and we may come back to you too, Mr. Verdi, just to you know, ask about other experiences that you had. You know, I'm curious about the blood patch. You know, I don't personally do these as a neurologist, although I see a lot of patients who have had CSF leaks, and many of these cases are very they're not as complicated. Sometimes, you know, we do a spinal tap for a diagnostic workup, and they end up having you know, a CSF leak that sometimes just rest and caffeine and medication is enough, right? Dr. Pack, I know you had mentioned doing blood patches, and I know a lot of anesthesiologists or pain medicine doctors will do that. Can you go over, like, how does that actually work? Like, if I refer a patient to you for a blood patch, you know, they just see you in the office and they get it done, or do they go into the hospital, or, you know, how does it work?
Sure. So, you know, we oftentimes will see patients as an outpatient. You know, some of our patients do come in through kind of the emergency room because their headaches are a little bit unrelenting, and oftentimes we'll do it in the hospital. But I'll say, you know, we do see a lot of patients on the outpatient setting. When we do get referred those patients and we confirm the diagnosis and the clinical symptoms seem pretty clear, then the epidural blood patch itself is you know, I think, I don't want to say simple, but a fairly straightforward process. So after we do our evaluation, typically what we like to do is do the procedure under fluoroscopy. So that not only enables us to choose the level where we're going to place the blood patch, but also enables us to make sure that we don't cause a secondary dural tear, right? So when we're doing these blood patches, we're accessing what's called the epidural space. And of course, as you place another needle there, there's always a risk of causing another dural tear, right? So that's the reason why we use the fluoroscopy machine. So after we do that, you know, oftentimes the most difficult part is getting the blood. So we try to get the blood as sterilely as possible. So the entire procedure is done sterilely. And normally, after we get access to the epidural space, you know, we will usually place, depending on the level, anywhere from, I think, 5 to 15 cc's of the patient's own blood. And after that's done, usually we'll have the patient lie on their back and be in the supine position for about an hour. And after that, we'll kind of test it out, right? So we'll have them sit up and see how they feel. And then usually most people after about an hour or so have a substantial relief of their symptoms. Again, that's dependent on the cause of the tear and where it's located. But for a lot of these patients, they usually go home after an hour after that procedure.
And in your, I know Mr. Verdi had a few of these, but unfortunately they didn't really seem to stick, probably because of the reason for his leak. In your experience, do a lot of patients get benefit from this and they end up doing okay?
So yeah, so a lot of the patients that we see are a result of lumbar punctures. So for example, we can look at the procedure note and to see exactly where that tear potentially would have occurred. And oftentimes it's after things like epidural steroid injections, where again we use fairly small needles, and so the puncture site tends to be pretty small. And so for that reason, obviously Mr. Verde's situation is a little bit different, a little bit more complex. But when the tear is small in nature, tends to be just in the posterior portion of the dura, for example, then getting access to that area is fairly straightforward, and being able to patch it up with the blood in that area, there's a higher success rate. So for those patients, they tend to do pretty well.
Got it. And then Dr. Chazen, as a radiologist, I guess many people might not know that you actually interact with patients. You're not just looking at a screen and images the whole time. I've sent quite a number of patients to him, and they all love you. You do interventions, right? So you've done like the fibrin injections, and you've done other interventions, to the spine. Can you talk a little bit about how that works and why patients come to you as opposed to other doctors for this kind of thing? You're muted. There
Sorry
you go.
about that.
No worries.
I'm sure. Yeah. So, I'm involved in both the diagnostic portion of this and do a lot of these myelograms, and as well as some of the interventions. As Dan mentioned, the blood patching, for example, is very effective if it's from a prior lumbar puncture or spinal tap. Over 90% rate that's really going to fix up the leak and it'll get better. In fact, a lot of these leaks after a spinal tap will get better on their own if you give it enough time. But the blood patch is highly, highly effective. But the other interventions, it really have to be targeted to the type of leak, where the leak's coming from, et cetera. So it's they're all under the CSF leak umbrella, but it's almost like 4 or 5 different sort of sub diseases, that are causing this. I mean, the common result of spinal fluid isn't where it should be, and patients often have orthostatic headache. But it really depends on the intervention type. And this is a very active area in the literature. It's an area, there are new articles all the time. As I mentioned, these fistulas really only described past 5 years. So to be at a tertiary referral center with excellent neurologists, neurosurgeons, anesthesia, and just really had to have a multidisciplinary team together to diagnose and treat these. That's really what's critical.
And there's a question in the chat here, and it's, I guess, kind of similar to Mr. Verity's experience. How many times do you see cases where you see maybe on the MRI of the brain, you see brain sag, you see certain signs that we saw, or that enhancement that goes around, and you just can't find the leak on the imaging? Is that a very common scenario, or does that not happen that often?
It's a great question. So if a patient presents with an orthostatic headache and they have characteristic changes on the brain MRI, some of the things we showed you before, there's a leak somewhere. It's just a matter of us finding it. And frankly, sometimes it'll take 4 different myelograms, but we'll stick with it and we'll find them. And in those cases where there are imaging changes of a spinal fluid leak, we're relentless. We'll stick with it until we find the leak and treat it. So it's very unusual if you have imaging changes in the brain MRI that we can't find a leak somewhere. The more challenging type of patient is, depending on what you read in the literature, there are probably about 5-10% of patients that have a spinal fluid leak, but their brain MRI is normal. Or symptoms are really just classic orthostatic headache, but they don't have any of the imaging changes. Those cases, we'll do the myelogram, we'll certainly do a thorough workup, but sometimes there are a few entities that can sort of masquerade as spinal fluid leak, and that's where it gets a little more tricky.
Got it. There's kind of a technical question that you might be able to answer here, Dr. Chazen, and we're going to be wrapping up in a few minutes, but I just want to answer as many of these as we can. Do you use the SIH score developed from a group of doctors in Bern, Switzerland, to read the brain images and diagnose the probability of having a leak depending on those sides in the brain?
Yeah, the scoring is helpful, but in a way, it's helpful for those equivocal cases. I'd say most of the cases that come in, classic symptoms, the brain imaging really, there's no question. there, you know, like I said, there's a leak somewhere, and it's really, it's just a matter of finding it. There are some patients where maybe that you have some of the symptoms, a little bit of brain sag, some of the sinuses are kind of in between. So then sometimes some of those quantitative scores can help tip us one way or the other. And some patients, you know, it's been reported we found patients where there is a leak and the brain imaging is normal and they have a very low score.
Great. I guess, you know, there were a couple of questions here, you know, for the really complicated cases, I guess, like Mr. Verdi's, when you have, you know, bad subdural hematomas and things like that. You know, there was a question about, do you ever need to end up doing craniotomies or meningeal artery embolizations? Maybe Dr. Greenfield, you can talk about that more, the surgical nature of these things.
Yeah, well, Mr. Verdi knows that he's been on the OR schedule for the last 3 months. He keeps running away. But we were quite worried, and I think it's a really good question because, you know, we don't really know if that blood is going to completely resorb when it's reached that dimension. You know, when you have a small sliver of blood, we expect the brain will re-expand. We were obviously a little bit apprehensive about the idea of letting that sit around. It can irritate the brain and cause problems for sure. In his case, we've been sort of vigilant and watching it with sequential MRI scans, and the hematoma has been going away over time, and the body will likely resorb it. He probably will avoid surgery. So, you know, if you take out a subdural and you don't fix the leak, the subdural is just going to come back, right? So the idea is fix the leak and see what happens. And there are probably cases that we'll encounter where we have to balance the two, and surgery sometimes will be necessary. But I think the overarching idea here is that surgery is probably going to be a minority of cases, and fixing the underlying pathology is going to be the answer.
All right, well, we are actually running a little overtime. This was really fantastic. Thank you all to the speakers. Mr. Verdi, really appreciate you spending your time with us and describing your experiences. So just to remind people, if anyone needs to see us in the Spine Center, any of us, we've got our information up here, and have a great day. Enjoy the good weather.
Thanks, everyone.